Hello there, welcome back. My name is Dr. Carlo Ojer, board certified emergency physician, and if you're watching this video, it's because you are already on your way to becoming an RVU master. You have downloaded the critical care reference card, you're reviewing it and kind of opening your eyes to what constitutes critical care, and as soon as your next shift, you're already kind of like, oh, wait, this is critical care. And by increasing that documentation, one patient each shift, you're going to make massive improvements on your overall RVUs per hour. You're going to become an RVU master. But I want to take this opportunity in this video to go through the card and go through the things for those that might have questions or they want to just kind of watch this video and learn with me. There are things that are obvious, okay? But there are things that are not so obvious, and I was very impressed and surprised to see them here. And then when I discuss with some doctors, they're like, oh yeah, absolutely, that's critical care. I'm like, oh. So I let a lot of those opportunities go through my hands and miss that opportunity. So let's get through it. Anytime you're giving like cardiac medications, for example, RioPro and any kind of like Integralin for a STEMI or something like that, obviously that condition is already pretty critical. So you're going to be an opportunity for document. Adenocard, if you're giving more than one dose, so a patient with SVT that the first 6 milligrams didn't help, you end up giving 12 or a third 12. That patient has a significant tachycardia that can deteriorate into a worse condition, and you're giving critical medications. I mean, ask yourself, if you didn't do the Adenocard, the nurse will be on you, this patient's heart rate is still 130, 140, 150, whatever, right? So you are actively treating an abnormal vital sign, and you're doing reassessment, you're doing face-to-face contact with that patient. So this was pretty impressive, acetadote IV or Mucomist. If you're giving it, it's because the patient has taken a significant injection of Tylenol and you've already consulted with probably poison control. That condition, if not treated adequately, could deteriorate. This patient is already mental health probably because they're suicidal and so on. So they're going to need close watch. So definitely consider critical care. Even though they look good, their vital signs are normal, and ultimately they're going to be discharged to a psych unit if their second, third Tylenol are normal or whatever. But definitely consider if you're already pulling the trigger on giving acetadote. Aggrastat falls into that category of cardiac meds, amiodarone and so on. Atropine, obviously, if you're giving it, you already pull the trigger on atropine. It's because the bradycardia is significant enough that is symptomatic or low enough that you're worried about deterioration. So that by itself constitutes critical care. Then you get Ativan, and we give tons of Ativan, right? But it's more than one dose. So you're giving one, the patient's not adequately sedated, you're giving a second one. So if you're giving a second, that means the patient needed reassessment. You needed to look at them again. And then you needed to give that second dose. So anytime you're giving more than one parenteral medication for sedation, consider critical care time on those patients because they need reassessments, because they need to check on them, because the intervention of the sedation is critical to the patient's well-being. If you're treating actively hyperkalemia, calcium chloride, calcium gluconate, or Kayexalin, someone that shows up later on. Anytime you're starting Cardine, that's a vasoactive cardiac medication, so that's clear-cut critical care. But more than one dose of Cardicem. Now, sometimes I used to give Cardicem, through IV boluses because I wanted to avoid the IV drip, because if I don't give them the drip, they can go to PCU or maybe telemetry bed, and I'm just trying to save the ICU bed. But you know what, however you do it, if you give multiple doses to control their heart rate, that still will qualify as critical, even though they ended up going to a PCU or regular floor, because you're giving it because of a normal vital sign, which is the heart rate, right? Anytime you're giving Crofab, I mean, those patients, you consulted poison control, you have to do neuro assessments, you have to check on them again and again. Even the process of decision of giving the Crofab is because they already have swelling or potential abnormal threat to a limb, right? Because of the snake bite or whatever it is. D5W. Now, we have a lot of hypoglycemics. We give them one dose, boom, they go up, and they're fine. Their blood sugar stays normal. But there's some of them, the sugar after a half hour, 45 minutes, starts to plummet, and you give a second one. Well, those patients are critical because hypoglycemia can be severe. Obviously, strokes and the somnolence and respiratory stress and those kinds of things. So you give more than one dose of D50, consider critical care. Diazepam, especially for status epilepticus. Or if you give diazepam multiple times, anytime you give a parenteral med multiple times, the potential for critical care is there. So we already talked about diltiazem, digipine, any kind of cardiac med to increase blood pressure like dobutamine, epinephrine, and so on. Epi sub-Q for anaphylaxis. They have a bad allergic reaction. They have a little bit of wheezing. Their tongue is getting a little bit swollen. You know what? They might be a little tachycardic. They don't not that sick, but they're in early anaphylaxis, and you pull the trigger on not just doing the regular Pepcid and Benadryl and all those kinds of things, but you pull the trigger on Epi, giving it sub-Q or IM or whatever. And that by itself is a critical intervention, because if you wouldn't have done that, the patient could have deteriorated. You have to do reassessments on the patient's breathing, on their mucosa, on their wheezing. So that's why that patient is critical. More than one dose of furosemide. The patient has mild to moderate CHF, and you have to give Lasix, but you have to give more than one Lasix. That means they're more critical. That means you have to reassess the patient. You have to make the decision to give another dose. Maybe you're already consulting with cardiac or pulmonary and so on. So that esmolol, obviously, glucagon, but glucagon for like recurrent or refractory hypoglycemia, not just for a foreign body of the esophagus. Although a foreign body of the esophagus, if they have complete obstruction, that's a critical intervention. You're calling GI, you're giving the glucagon, even though it doesn't work, and you're doing this all the things. You're doing an X-ray, you make sure that you don't have mediastinitis, you put that on your differential, you do multiple reassessments. So because all of that you did and all of the differential potential troubles that you prevented, that becomes critical care. Multiple doses of any parenteral medication for agitation. Again, psych patients, they can be decompensated. You have to reassess them and so on. Anytime you give heparin for P or ACS, they have a partially elevated troponin. You've determined. So heparin itself is the critical intervention. You're preventing progression of an acute MI. So even though they're stable vital signs, they're up and talking to you, that's a critical intervention. Obviously, insulin drip, that goes to the ICU, at least in my facility, that clearly is. Any time of hyperkalemia treatment that's active. Labetalol, more than one dose, a patient comes significantly hypertensive. You give one dose, you wait 15 minutes, they're still high, you give a second dose, and then you switch over to oral. Maybe they end up going home. So that's another misconception about critical care. They all have to be admitted to the ICU, and that's just not true. They can even go home, although that should be pretty rare. Obviously, any kind of pressors, lidocaine IV, because they have multiple PVCs or whatever, and you want to treat that. So anytime you give like a medication multiple times, especially if it's IV, low pressure is there, and then there's metoprolol, more than 3 doses. So more than 3 doses of that vasoactive drug to decrease their heart rate or blood pressure, then you should consider. We talk about heparin, now Lovenox is here. Mannitol, you're treating rhabdo, you're treating intracerebral pressure, and you give mannitol to prevent this or to actively treat it. That's a critical intervention. We already talked about mucomis under N-acetylcysteine, but also giving a PO is for the same reason. Narcan. These patients sometimes walk out of the ER, right? They get their Narcan, they're better, but you did reassessments. You check them again. Maybe you counsel them for drugs. You run them a prescription of Narcan for home. These patients are critical, and you spent the time treating them, assessing them, reassessing them, and educating them before discharge. Natricor, not sure anybody uses that anymore, but I certainly did a bunch of times. Nicardipine, Niprid, all those cardioactive medications are definitely potentially critical. Status epilepticus doesn't get any more emergency or critical than that. Oxytocin, Pitocin, hopefully we're not doing that in your shop, but it could be, and if you do, you should consider that. If you're given severe hypokalemia, and that's discussed here under electrolyte imbalances, you should consider writing procainamide. I like procainamide in an IV piggy bag, 1 gram IV over 1 hour to cardiovernions at AFib, and it works more than 60-70% of the time. So if the patient has onset AFib and I start procainamide drip and I do reassessment, all of a sudden their sinus, they end up going home. But for the time they were in the emergency department, for the time I was treating them, they were definitely critical. And sodium bicarb, they were significantly acidotic. Theophylline, you're definitely talking to pulmonary about using something like that. Obviously thrombolytics, if you don't have a cath lab and things like that, multiple seizures or severe agitation. Again, severe agitation is showing up again and again, and that's a potential that most everybody's losing, because we think, oh, those patients are just going to be sent to a psych facility. Yeah, but by the time they were in the ER, you need to assess them, to reassess them, to check on them. They became agitated, they came out of the room, they were combative. Document that. Reassessments and the need for medications, that makes them critical because they could deteriorate and decompensate. Now let's talk about critical vital signs and labs. Obviously, significantly abnormal vital signs, that's the ultra definition of critical care, right? But consistent with organ failure, so somebody's tachycardia of 115 and has rhabdo and AKI, that's critical. They need fluids, they need hydration, they need close watch. That's what you're admitting them. So that could be critical. Saturations that are low, and that's less than 90. How many of those did we see with COVID? How many of those did we actually document critical care time? No, we just put them on blow-by. They were 92. We admitted them. So just the fact that you're putting them on blow-by for an 89, 88, it doesn't make them critical, but you got to put in the context of how much medical decision-making happened. How many reassessments did you do? Did you do any consultations? And that adds to the picture and justifies the critical care. Obviously, significantly abnormal respirations, distress of breathing, and then you document your retractions, your Cheyenne-Stokes, your nasal flaring, abdominal breathing, and things like that. Significantly abnormal temperatures, heart rate changes, blood pressure. And you know what? I'm sometimes like a minimizer, but if somebody meets that blood pressure in 230 over 130, I'm going to be treating that. I'm going to start a vasoactive drug, Cardine or whatever, or Esmolol, or low pressure, or Labidol IV, or whatever. Those patients are critical. You're going to end up admitting them for controlled blood pressure. So consider that. GCS of less than 12. And electrolyte imbalances, sodiums that are too low, too high, potassium, calcium. When they call you on the phone, hey doc, I have a critical lab for you. Is this patient critical? Yeah, it's a critical lab. You have to do a critical determination. So anytime you get that phone call for a critical result from lab, from radiology, then consider documented critical care time. You're certainly not going to ignore that, right? Bicarb, low platelets, obviously a very abnormal ABG because of PCO2 or the PO2, pH being too low or too high. Any significant hemoglobin that's low, you're going to end up giving blood. Even though it's chronic and they look stable, you're not going to send that patient home. You're determining that they need the blood. Therefore, the intervention is critical. So just as long as your medical decision-making is there, you did your rectal exam for bleeding, you assess them for bruise, you make it, you prove that you spend the time with the patient and that intervention was critical. Elevated troponins, very significantly elevated white counts point to more severe disease. So definitely consider critical care time in those patients. So let's go to the next one. This is kind of cool because it's got some clinical cases and scenarios. So we got medications, so we discussed that already. You got procedures. Now, a lot of procedures are separate billables, so they're not part of critical care time, but just the fact that you did them puts the patient as a marker of critical care. So obviously if you're doing a central line, if you're intubating, if you're managing the vent because you're reassessing ABGs and so on, you're doing a chest tube for a pneumothorax, pericardiocentesis. These here, crico, IOs, by definition, point to a sick patient, right? So you should definitely consider documented critical care. In our facility, BiPAPs go to the ICU or at least PCU. Unless they're chronically CPAPs, they go to the floor or something like that. So consider that. But if you're pouring on high flow oxygen mask and non-rebreather because of significant hypoxia, then you should definitely consider doing critical care. More than 2 liters of fluid or 20 cc's per kilo in a kid, that's an acute bolus of hydration for somebody who's sick. So you should consider doing that. We already talked about transfusion of blood and O negative. If you're doing O negative, that patient's ultra sick, or you're presuming that they're ultra sick, so you're definitely going to do that. Unstable vital signs, you're trying to prevent deterioration. Time and after CPR. The CPR itself, the time spent on CPR is separate billable, has its own code, so you cannot bill for that. But after CPR is completed, now you are putting a central line, so that time doesn't count either. But you're managing the vent, you're reassessing the ABGs, you're calling consultants. So that other time is considered critical care time, and you should document it. Any patient that urgently needs to go to the OR. esophageal perforation, thoracic dissections, perforated bowel with free air, ectopic pregnancies. Those patients, by definition, they needed a critical intervention. Even though you didn't perform it, you certainly spend the time with them, and you should consider doing that. Fournier's gangrene, obviously sepsis and things like that. Trauma. Now, ultimately, the final diagnosis might be lumbar strain. But while you were doing the workup, you were doing CT head and belly and chest, and their tachycardia, and you're giving fluids. Because of all that you're doing is what makes it critical, not the ultimate diagnosis. Post-traumatic quadriplegia, paraplegia, cord syndrome and things like that, obviously. Cervical fracture, subluxation, with or without neurological deficit. So they don't have to have a deficit. If the fracture is significant enough, you get in a surgery consult, you're stabilizing their neck or whatever. That intervention, that workup is critical. Stab wounds, and gunshot wounds. Those are high-risk injuries. You're calling trauma alerts. You're calling a surgeon. You're doing multiple interventions. You're doing OR exploration and so on. Obtundation, if a significant altered GCS, obviously less than 12. A tension pneumo, or not tension but large enough, 25%. A hemothorax, obviously. Anybody requires a fasciotomy. That's clear. Anybody would know that. Burns with escharotomy. Ankulated fractures or dislocations with skin tenting. That's a surprising one for me. So if you decide to reduce because there is skin tenting, because there's significant angulation, you're preventing deterioration of vascular status, so you're preventing injury to arm or limb, so life or limb. So this is potentially serious, so consider that. Acute STEMI, obviously. But the problem is, in my shop, acute STEMIs last 5-7 minutes and they go out, right? On weekends, they might last 15-17 minutes and they go to cath lab. But you know what? You spend the time writing the chart, reviewing the labs, reviewing the x-ray, talking to consultants, maybe reassessing the patient later to see what they found, what they stented, and that is considered time involved in patient care, so you can document your critical care time. ACS that requires heparin, we talk about that. Accelerated hypertension requiring IV medications, multiple doses. CVAs that you give TPA, or ultimately that you did not give TPA, but you were considering giving TPA, you got neuro involved, you do the consult, ultimately you decide not to. But for that time you spend, those 30-something minutes you spend doing the evaluation and treatment, you definitely, patient was critical. Hemorrhagic CVA, subarachnoid, especially if you give him FFPs, you give medicines to counteract bleeding and things like that, then you should consider that as well. Traumatic subdurals, epidural hematoma, depressed cold fractures, all have the potential for deterioration. Chemical cardioversion, so what I was talking before about prokinamide or any kind of IV drug for cardioversion, especially if they're symptomatic, they have chest pain, shortness of breath, they're sweaty, you're doing because they're symptomatic. And also, that's clear, electrical cardioversion. If you're zapping somebody, critical care, right? If you use pacemaker, clearly. Patient unstable, we already talked about that. They're cold enough, they need a bear hugger. You should definitely do that. Any BiPAP, CPAP, high flow oxygen, anybody you intubate, active treatment of PE. Even if they just go to PCU or the floor, the diagnosis by itself is a marker of critical care. Significant dehydration, you give tons of fluids, rhabdo, DKA, and so on. Treatment of any kind of significant electrolyte abnormalities, hyperkalemia, hypercalcemia, hypernatremia. Foreign body ingestion that requires airway control, obviously. Mesenteric ischemia, they have high lactic acids, you give them tons of hydration. GI bleeders that you call in GI consults on, you're having blood on hold and things like that. We already talked about snake bites, mesenteric thrombosis, stridor, any kind of external evidence of distress that alerted you, that made you, hey doc, we need a doc in room 2. Critical care, Anemia, especially with active bleeding. Now, if the anemia is low enough and you have to give blood, like anemia 5, that's a critical finding, right? You're going to give blood to. So, and we already talked about these, sepsis, bacteremia, meningitis. So, that's a long video. Sorry about that. But here you see the potential. Like, you probably didn't think some of these were critical. And as long as you have the medical decision making, the interventions, the reassessments, as long as you document it right, you can document critical care time. And if you bump up your critical care from 1% to 2%, from 2 to 3, maybe from 3 to 5%, then you're going to be gaining tons of RVU, and ultimately you too will be an, oh man, there you go. You too will be an RVU master. All right, so I hope you enjoyed this video. I hope you find it of tons of value, and I hope it helps you on your next shift, because it helped me when I was doing the research, when I was doing the learning for it. So we'll see you on our next video. Take care. Oh, fudge.